The next symposium will focus on neurology, addressing both challenging and commonly encountered neurological conditions. Please join me in welcoming the chairpersons for this session, Dr. Padma S. Wijeratne, Consultant Neurologist, National Hospital of Sri Lanka, and Dr. Kishara Wijeratne, Lecturer in Medicine, Faculty of Medicine, University of Moratuwa, and Consultant Neurologist. They will lead us through this session. Over to you.
Right, let me very warmly welcome all of you to the 10th Symposium of the Ceylon College of Academic Sessions of the Ceylon College of Physicians on Neurology. I all the time think that the symposium before lunch will be better concentrated than the after lunch. So I think in that sense we are somewhat all right. So to commence the proceedings, let me introduce to you our first speaker, my good friend, Dr. Professor Tissa Wijeratne. Professor Tissa Wijeratne is the President, Asian Regional Consortium for Headache, and Director, Department of Neurology and Stroke Services, Department of Neurology, and Professor, RMIT University, Melbourne, Australia. So Tissa is not anyone new to the medical audience here in Sri Lanka. He has made a significant contribution to global neurological research and education with 367 publications, with over 122,000 citations and an H-index of 81, highlighting his profound impact on the field. Professor Wijeratne has spearheaded more than 100 clinical trials and has been pivotal in training over 450 physicians since 2006, including guiding 56 PhD candidates to successful completion. He was instrumental in founding the Australian and New Zealand Headache Society and the Australian Institute of Migraine. So based on all these contributions to the Australian community, he was awarded with the Medal of the Order of Australia in 2023. So with that brief introduction, let me invite Dr. Professor Wijeratne to make his presentation on headaches for non-neurologists.
Thank you very much, Padma, for kind introduction, and thank you very much for you to invite me to the CCSP sessions first years back when you were the president. And thank you, Full, for twisting my arms while I was flatly refusing to come to Sri Lanka during election time, convincing me that it will all be safe and you will have a terrific time. And I can echo that first couple of hours since arrival, it has been just sheer joy. So the learning objectives of this talk is, hopefully I will convince you that headache disorders impact over 3 billion people worldwide, probably including almost half of you in the audience, certainly myself. And hopefully understand the basic concepts between what is known as primary headache disorders and secondary headache disorders. And then hopefully you would go home realizing that migraine, that impact over 1 billion people worldwide, is the most neglected, worst managed, least respected medical disorder worldwide, including Australia and Sri Lanka. Although Kishar and Padma might disagree that I can't comment on Sri Lanka, I travel here quite often, so I do hear a lot of horror stories which are not different from Australian stories. And also you would go home learning some basic concepts of the need for mastering the art of headache medicine, as it is one of the most rewarding aspects of any physician, as you will help these patients immensely to get their life back by learning basic concepts such as lifestyle, seeds, over-the-counter medications, and rational prescribing if time permits. So I know that it is difficult to do this within 20 minutes, but I'll try my best to infect your heads with some good ideas so that you can work on them. You will have access to my slides and you can Google my name, and most of the things that I have done in the world is freely available via web. I have no particular conflict of interest. Padma has already mentioned my conflicts before. So my agenda for the next 18 minutes or so is I'll hopefully convince why should we care. And then I will go through basic ideas of primary and secondary headaches, migraine, such a terrible, painful truth, and Snoop 12 that we published on few clinical, the pearls on history taking, and final tips and takeaways. So this is a paper that I was unfortunate enough to co-author, as this paper told staggering statistics to the world, saying that we are being controlled or led by global leaders who got sick brains, because 50% of them are having a brain disorder at this point of time, including most of the prime ministers and presidents worldwide. That's 3.4 billion people. That's almost 1 in 2, but at least 1 in 3. And to make matters worse, neurological disorders impact more so in a country like Sri Lanka than a country like Australia, because they affect low to middle income countries more terribly. If you look at the GBDA paper that we wrote, I'm currently generating the main manuscript on migraine for Lancet Neurology, which I hope to submit before the end of the year. Migraine affects over 1.16 billion people, and it is indeed the leading cause of disability among children, 5 to 19 years worldwide. It is indeed the leading cause of disability among all ages in Australia, New Zealand, and most European countries. And it is indeed the leading cause of disability among women. And it is indeed the second leading cause of disability across all gender groups below 60. And it is the second disabler for several other countries also. But a bunch of us are promoting what is known as preventive neurology that hasn't taken up by most nations. We believe that most of the neurological disorders can be prevented, and we believe that migraine also play a significant role here. We publish and in the process of publishing an editorial on Life's 10 for brain health, and we have seen a couple of publications supporting that these are helpful to alleviate discomfort in most of these people. Now let me move the talk to what are known as primary headache disorders. I don't like this classification because all headaches should be secondary, but this is what we got. We lump a bunch of headache disorders into primary headache disorders. These are basically types of headaches that are there because the disorder is themselves. There's no other disorder behind them causing them. The reason that personally I don't like it, in my curious mind always tell me that there's a cause behind migraine, tension, headache, and other types. So the moment that you lump them as primary, you stop researching on them significantly. But anyway, don't go home with that. The primary headache disorders that we know are migraine, tension type headaches, trigeminal autonomic cephalalgias, and other primary headache disorders. Now, if you Google International Classification of Headache Disorders 3, which is a freely available document for you from International Headache Society, you would see that migraine reclassified into several subtypes: ocular migraine, migraine with aura, chronic migraine, etc. Tension type headache, the same, acute, intermittent, chronic, probable, etc. But you're familiar with these two things, so I'm not going to dwell too much on those things. Just to remind you of other primary headache disorders, TACS, there is a classification up to 10. I'm not going to bore with all these things, but except to say that it is important to know some of these things. Say, for an example, nummular headache or coin-shaped headache. Kishar may recall that I published something in your local journal a few years back with the help of my good wife, who is a psychiatrist. And this is a specific rare disorder where you get a coin-shaped headache, and you need to know about them and have to see one of them to recognize the others. And then hypnic headache is another rare headache disorder where people wake up with a typical headache immediately after falling asleep, but exclusively respond to indomethacin or caffeine. Primary stabbing headaches, primary thunderclap headache, primary exercise headache, primary cough headache, primary sex headaches, etc. So just be aware that they do exist and they help you to help your patients better. And then secondary headache disorders, meaning that there is a different disorder contributing to the headache patient that is in front of you. Critically important to recognize this, as some of these things are life-threatening. Subarachnoid hemorrhage, for an example. You all know that there are 3 ways to diagnose subarachnoid hemorrhage: CT, lumbar puncture looking for CSF xanthochromia, and the third type, if anyone can give me the answer. What's the third way to diagnose subarachnoid hemorrhage? Postmortem. So you should never wait for that. That's why all suspected subarachnoid hemorrhage patients must have a LP and look for CSF xanthochromia. The yellow-coded picture on the slide is to remind you on medication overuse headache, which is the commonest secondary headache syndrome. These are patients who consume acute medications more often than 10 days per month for more than 3 months that cause their headache. That can only be fixed by fixing medication overuse headache. And one of the most misdiagnosed secondary headache disorder is secondary headache disorder 11.1 to 11.9. These are secondary headaches occur due to eye, ear, throat, sinuses, etc. I have seen more than 100 patients who had multiple expensive ENT surgeries for chronic migraine, while they got nothing to do with sinus issues in Australia, in UK, and other places. I'm sure it is probably not too dissimilar here also. So just be aware of secondary headache disorders. We spent significant time on this, including a recent publication that we generated through WFN official journal a few months back, talking about red flags and green flags. Remember that all these mnemonics and red flags, green flags wouldn't take away your gut feeling as a good physician or history taking and examination. They're there to help you. So the green flags are basically, as I mentioned, if the current headache has already been present during childhood, it is unlikely to be a life-threatening secondary headache disorder. If the headache disorder occur in temporary relationship menstrual cycle, it is unlikely to be going to be a nasty secondary headache disorder. And if the patient has a lot of headache-free days or crystal clear days, then it is unlikely to be a nasty headache disorder. And close family members having similar phenotype, again, is a green flag. Headache occurred or stopped more than 1 week ago, they're back to normal now, is a potential green flag, but not black and white. So the green flags basically let you relax. You can send them home and manage them easily. The red flags, which we add as SNOOP 12 with S2N2O and 12 Ps. Again, this is available freely and you will have access to my slides also. There's a pattern to recognize these things also. They help you to keep your patients alive and important to fix them up. So before I change this, I'll show this picture. This is a picture that my son took while we were in most up north Queensland a few days back. And this is a black-throated finch. Only very few humans would have the ability to picture this beautiful creature, as it is an endangered species, only occurred in most remote rural Australia in up north. So few clinical tips on headache history. I would like to spend about an hour or more on this. This is the most important part of my talk, but Upul will kill me if I spend too much time than what is allocated. But if you were to go home today thinking that when you take a headache history, remember that because this is such the neglected disorder, most of your patients, even with chronic headaches, are not forthcoming with history giving. So you need to be patient to extract the information from them. So change your terminology. Introduce them to headache-free days, crystal clear days, acute medication days, completely symptom-free days, etc. And you need to re-ask them to get the real story. It is pretty much like taking a history from a heavy alcohol-consuming person. They won't be forthcoming. I know as a migraine sufferer myself, the quick response is to run to the medication cabinet and then try ibuprofen, Panadol, or other things, because you have so many things to do next day. So again, ask with open-ended questions, and as the old wise men in medicine told us, listen to the patient. Quite often they are telling you the diagnosis. Ask from how long have they had headaches, and then get those things that I mentioned on the primary, secondary headache symptoms in your history as much as possible. And as I said, the very important to ask about the crystal clear days, in other words, completely symptom-free days and headache days. Most migraine patients, they don't tell you about non-severe migraine headaches, which are still migraine days. You want them to be completely crystal clear if you were to remove them from chronic migraine and chronic medication overuse headache. And then additional symptoms, and again, very important to ask about medication overuse in particular. Go deeper, what do they take? Paracetamol, the ibuprofen, rest of the other things, morphine-based medications, triptans, and other things. Most people think that paracetamol is a safe medication or ibuprofen is a safe medication. They all cause medication overuse headache if you overuse them, unfortunately. I have learned it practically by doing that a few years back. And then ask about whether there are more than one type of headache also. Ask about allodynia also. We did a migraine movie a few years back, which is available in YouTube. And there is one of my patients telling that the mom say that she can't hug her daughter. That is because the daughter is having cutaneous allodynia. You hug, it hurts. And many of your patients would tell them that they don't do hair anymore, or they don't go to hairdressers anymore, although they would love to because of the pain that it exacerbates because of chronic allodynia. And then don't forget about the caffeine intake and fizzy drink intake. I had patients who were drinking Coke cans 70, 80 per day, which penny only drops when I was retaking the history third visit or fourth visit. So just learn from those mistakes. Neurological examination. Neurology is probably the only specialty in internal medicine that we still have to take a history and examine. We don't have a test to replace them. Kishar and Padma will tell you that 50% of our referrals come to us with unexplained MRI results, and we have to take history. I have some physicians in Australia ring me whether I could send a team member to do a neurological examination because their team have forgotten how to do neurological examination. Given that almost half the world population suffering from a neurological disorder, we can't do this by ourselves. So please learn how to do a proper neurological examination and do them. Look for neck movements, look for movement disorders. Up to 5% of migraine patients do have cervical dystonia. It takes about 7 to 10 years to make the diagnosis sometimes. And the eye is the window to the brain. Don't forget the ophthalmoscope. Look at eye movements and look at pupils. And look at those the beautiful science that is telling you and help you to differentiate primary versus secondary headache disorders. I was intently watching the previous speaker, and the couple of our PhD students are working on the behavior of simple blood counts at different trajectory. So watch out the space on publications coming from our team that might change the way that we deal with most neurological disorders. This is another beautiful, majestic creature that we captured the last week while we were living on expired food in most northern Australia. This is the yellow-headed kingfisher, not endangered, but very difficult to see in other parts, and really difficult customer. He sang the song for like 7 days without appearing to show us as a Hollywood bird. So the final tips and take home. I talked about lifestyle. I didn't talk about treatment, but few tips on treatment which are not there in the slide. When you treat acute headaches, always teach your patient why we are treating them. We are treating an acute migraine to get rid of that within 2 hours and to keep them symptom-free next day morning. The scientific terminology for this is sustained pain-free response. You tell them that why we do that. You do that by hitting hard, hitting early, hitting well with NSAID or migraine-specific medication, but teach them on side effects. That's management of acute migraine. When it comes to prevention, it's a 3-pronged approach. The holistic way is lifestyle, over-the-counter medications, prescription medications targeted to your patient. You won't prescribe medication that is going to put on weight if your patient is already overweight. You won't put them on Sibelium or the flunarizine or propranolol if they are already depressed, as that could cause depression. Or if you put them on, just watch out. My sister with migraine almost committed suicide on flunarizine. Fortunately, we picked that up before she was going through the rabbit hole. So just watch the space for those things. Lifestyle-wise, easy to remember the word seeds: sleep, exercise, eat, drink healthy, diary, in other words, crystal clear days, acute medication days, headache days, and last S in S, seeds, stress management. As long as it is morally correct, anything that they can do to de-stress themselves is going to help them. If all humans practice good dose of seeds, they generate what is known as DOS, happy chemicals: dopamine, oxytocin, serotonin, endorphin. And there are a truckload of over-the-counter medications that are quite useful for migraine prevention: magnesium, vitamin B2, feverfew, melatonin, etc. And last but not least, every single patient with any headache disorder should never lose hope. I am primarily movement disorders trained. My PhD is in stroke, and I have done a lot of global neurology, and now I'm regarded as a big headache expert because I have been treating them and treating them well over the last decade or so. The reason behind that is the most rewarding aspect of my practice. So you give them their life back when you remove them from medication overuse and chronic migraine. It is such a happiness that you can get that you cannot put a price tag to it. So the way forward is, I won't run the video. This is a video that I done for the Australian Parliament on World Migraine Day, basically asking them to making our political institutions, schools, hospitals, universities, and other private sector migraine and brain health friendly, and promoting preventive neurology as a life course approach, and recommending political leaders that prevention is better than cure. So I used most of my own team's references, up to 17, to generate this talk. This is a snapshot, but we are bringing the 10th Asian Headache meeting to Sri Lanka on 18th of December at Hotel Galadari. I will be counting on my colleagues' support for that. So I would warmly encourage and invite all of you to join that meeting. You would have some of the best in the business, and there would be a wide assortment of everything related to headache, fixing headache in that meeting. And thank you so much for your patient attention. And that's, by the way, magnificent rifle bird that I shown on the last slide before, again from the last week capture.
Yeah, thank you, Tissa. I think we'll take the questions at the end. I'll thank you very much. So it's my pleasure to introduce the next speaker, who's no stranger to this audience. He's Professor Thashi Chang. He's a professor in neurology in the Department of Clinical Medicine at the Faculty of Medicine of the University of Colombo, and honorary consultant neurologist and professor of medicine, National Hospital of Sri Lanka. He graduated from the University of Colombo with first-class honors. He's a Commonwealth scholar and obtained a DPhil in clinical neurology from the University of Oxford, United Kingdom. He was the president of the Association of Sri Lankan Neurologists from 2019 to 2020. Over to you.
Thank you, Kishara, for those kind words of introduction. Good afternoon to all of you. At the outset, let me thank the President and the Council for inviting me to talk on CNS tuberculosis. I intend to illustrate the diagnostic and therapeutic challenges by presenting to you 2 clinical cases. And in the process, I want to highlight the challenges, the utility and the limitations of the diagnostics that are available to us today, the challenges in treatment of CNS TB, and a little bit on paradoxical reactions. I shall end this talk with adjunctive therapy in TB meningitis. So let us start with our first clinical scenario. It is a 24-year-old man who presented to the outpatient clinic with worsening daily headaches for 1 month. He has been feeling ill and anorexic during this period. His clinical examination was normal. He was prescribed 1 week of antibiotics and analgesics for a provisional diagnosis of sinusitis. He admitted 2 weeks later with reduced level of consciousness. His GCS was 10 out of 15. He did not have papilledema, focal neurological signs, or neck stiffness. An uncontrolled CT of his brain was normal, but his ESR was elevated at 100 millimeters per hour. His CSF was quite remarkable with an elevated CSF protein of 300 milligram per deciliter. He had a lymphocytic pleocytosis of about 270 lymphocytes and 20 polymorphs. And he has an extremely low glucose in his CSF. His Zeal-Nielsen stain for acid-fast bacilli, gene expert for Mycobacterium tuberculosis, and TB cultures were negative. However, a probable diagnosis of TB meningitis was made, and he was commenced on anti-TB therapy and steroids. Unfortunately, he progressed into a comatose state and died 1 week later. So despite commencing anti-TB therapy, the patient died. So that poses 2 questions. Was the diagnosis of TB meningitis correct? Why did he die? So let us answer those 2 questions. Was the diagnosis of TB meningitis correct? How did we make the diagnosis? Our diagnosis was primarily based on the typical CSF profile. So the diagnosis was hinged on the CSF profile. However, it wasn't taken in isolation. It was taken in context of a consistent clinical presentation. And this was supported by a remarkably elevated ESR. You will note that all his microbiological assays were negative. Now, when we make a diagnosis of an organism causing a disease, we need to isolate the organism at the site of pathology. In the case of CNS TB, it is in the CSF. That will give us a definitive diagnosis. When we cannot isolate the culprit pathogen, then we go a tier below. That is the probable diagnosis. So in this patient, we made a probable diagnosis of TB meningitis. So the next question is, why did he die? So one was the delay in diagnosis. Now you heard a fantastic lecture on headaches. And as you heard, headaches are a very common symptom. All of us in this audience, there's probably no one who would not have had a headache. But you would know that headaches usually resolve in a few days. Now here is a patient who has a worsening headache going on for a month. And the worsening headache, it starts with a mild headache, then it becomes moderate, and then it becomes significantly intrusive. So here is a worsening headache over a protracted period of time. Now, that is a very sinister feature that should have rung alarm bells. And furthermore, it was associated with constitutional symptoms. The patient was feeling ill, and the patient was anorexic. So the patient warranted evaluation at that point. And unfortunately, obviously, that was missed. And that is why the delay in the diagnosis. So the next question is, did the delay in diagnosis contribute to his death? The outcome of TB meningitis greatly depends on the stage at which anti-TB therapy is commenced. Now, TB meningitis have 3 stages. It's not difficult to remember that. It's very easy. Stage 1 is they only have consistent symptoms. There are no signs whatsoever. So very easy. GCS 15, only symptoms. In stage 2, either there is a marginal reduction in the GCS or the patient has focal neurological signs. And in stage 3, there's a reduction of the GCS significantly below 10, irrespective of whether there are focal neurological signs or not. So very easy to remember the 3 stages. But what I want you to note are the numbers. If you start anti-TB therapy in stage 1, the mortality is just 18%. Whereas if you start anti-TB therapy in stage 3, it goes as high as 72%. So our patient, when he presented for the first time, he only had symptoms. He was in stage 1. And had he been evaluated and treated at that point, perhaps he would have survived. So there are 3 very important learning points from this clinical case, and that was the reason why I presented it to you. You need to have a high index of clinical suspicion to make a diagnosis of CNS TB. particularly in TB endemic areas. But it holds true for TB non-endemic areas also, because global travel is so much these days. And the second important lesson we learned from this patient is that isolation of Mycobacterium tuberculosis from CSF is notoriously difficult. So it is all very difficult to make a definitive diagnosis. So we rely on probable diagnosis. And the most important take-home message is that anti-TB therapy should be commenced immediately on strong clinical suspicion, because delay in commencing anti-TB therapy, as you saw in the previous slide, would result in an increased mortality, and that's what happened to our patient. Now let us look at CNS tuberculosis in a bit more detail. There are two forms. There's the intracranial form, there's a spinal form. The intracranial form includes tuberculous meningitis, tuberculoma, tuberculous abscess, tuberculous encephalopathy. And the spinal forms have POTS paraplegia, which is actually vertebral body TB rather than neurological TB. There are extradural cord tuberculomas or abscesses, and tuberculous radiculomyelitis. Of these, the most common and the most severe is TB meningitis. So let us look at TB meningitis with a bit more detail. And specifically in TB meningitis, let us look at its clinical presentation, because you need to recognize TB meningitis when you see it. So TB meningitis have three phases of presentation. The first phase is a prodromal phase, where there is an insidious onset of malaise, lassitude, headache, a low-grade evening pyrexia, night sweats, loss of appetite, loss of weight. These are together known as constitutional symptoms. The next phase is the meningitic phase, where the patient develops meningism. The headache gets worse and worse, protracted. The patient develops vomiting, lethargy, confusion, and varying degrees of cranial nerve palsies. And then in the third, the paralytic phase, the pace of illness may accelerate rapidly. Confusion gives way to frank coma, seizures, and often hemiparesis. So that is the typical clinical presentation of TB meningitis. Now let us look at the utility and the limitation of the diagnostics that are available for TB meningitis. On this slide, you can see a Ziehl-Neeson stain, and the reddish rods are your Mycobacterium tuberculosis. Now, according to the Cox postulate, if you are to make a definitive diagnosis, you need to isolate or demonstrate the organism at the site of pathology. So in the case of CNS TB, it is in the CSF. Definitive diagnosis, therefore, depends on identifying or isolating Mycobacterium tuberculosis in the CSF. And these are the investigations that we have as microbiological assays. And what should strike you is that the remarkably low sensitivity of these tests. Ziehl-Neeson tests have a sensitivity of about 5 to 20%. And the gold standard, TB culture is considered as the gold standard, but it has a sensitivity of only 40%. And if you take all the reference laboratories, the best reference laboratories, and look at the PCR, it still has a sensitivity between 50 to 60%. So none of these investigations can rule out TB meningitis. If it's there, it is supportive of the diagnosis. But a negative test does not rule out the diagnosis. So that's very important concept to understand. What about the gene expert? The gene expert is an automated nucleic acid amplification assay that can simultaneously detect Mycobacterium tuberculosis and rifampicin resistance. Because of this, this is now the WHO recommended assay worldwide. It has a fantastic specificity, almost 100%. But the sensitivity again is remarkably low. Because it is low in CSF, it again can rule in a diagnosis, but it is insufficiently sensitive to rule out a diagnosis. In other words, a negative gene expert does not rule out a diagnosis of CNS TB. Remember that, that's so important. So now we looked at the diagnosis. How do we make a diagnosis of TB? The first and foremost, if to make a definitive diagnosis, you need to isolate the organism. I told you how difficult that is. So then we looked at the CSF profile, because that is the one that really helps us in the diagnosis in the correct clinical context. So what do we see as a typical CSF profile in TB? There will be a remarkably elevated protein. There would be a lymphocytic pleocytosis and extremely low glucose. So this is very typical of TB meningitis. But the problem is, it is not specific for TB meningitis. You will find it in pyogenic meningitis. You will find it in fungal infections. You will find it in brucellosis. So although in the correct clinical context, it will support the diagnosis, it is not specific for TB meningitis. Now, because we rely so much on the typical CSF profile, I want to share 4 caveats with you with regards to CSF. The first and foremost is, even in TB meningitis, in a minority, it can be acellular. And in a minority, it can be having normal proteins. And in about a fifth of patients, instead of a lymphocytic pleocytosis, they might have a neutrophilic pleocytosis, especially in the initial stages of TB meningitis. The second caveat is that extremely low glucose. You can remember it as the 40-40 rule, less than 40 milligram per deciliter or less than 40% of the random plasma glucose is highly suggestive of TB meningitis. And the third caveat is that we depend so much on the ratio of glucose between CSF and plasma. However, in hyperglycemic states, it is not reliable. Why is that so? Because it depends on the glucose transport across the blood-brain barrier depends on the GLUT1 receptor, the transporter. And that gets saturated when the glucose is very high. So in that situation, you need to depend on the absolute glucose rather than the very high glucose, rather than the ratio. And finally, the most important caveat is that the over-reliance of ADA levels. Now, ADA levels have not been standardized for CSF, and there are no reliable cutoffs. ADS is a fantastic test for the pleural fluid, but absolutely poor for TB meningitis, because even in the studies that they have done in India, it has a low sensitivity and specificity, right? So I see that there's an over-reliance of ADA when it comes to CSF, CNS TB, because of the extrapolation from pulmonary TB and extrapulmonary pleural TB. Now, we have been depending on the CSF profile and the microbiological assays, and we found that the clinical presentation. So those are the 3 things in the diagnosis: the clinical presentation, which we described for TB, the microbiological assays, and finally the CSF profile. And what we have learned is that the CSF profile is the one that we hinge our diagnosis on in the correct clinical context. Now, when we can't make a definitive diagnosis, we base our diagnosis on a probable diagnosis. And that depends on multiple sources of evidence. And one other important evidence that we take is neuroimaging. Now, before I go on to neuroimaging, I need to emphasize that if ever you are looking for inflammation in the CNS, always ask for contrast, because contrast will concentrate where there is inflammation and show you the lesions. The opposite is also true. If you do not give contrast, you will end up missing the lesion. So it's so important. That's an important take-home message. Always ask for contrast when you're looking for inflammation. Now let us look at the typical neuroimaging findings in TB. The most common and most typical would be basal enhancement and hydrocephalus. On left, you will see a contrast-enhanced CT brain showing both hydrocephalus and basal meningeal enhancement and exudate. On the right, you see a T1 weighted MRI with contrast, again showing you the basal enhancement. You will see tuberculomas, the typical tuberculoma, a ring-enhancing lesion with the central caseous necrosis, and perilesional edema causing mass effect. Now, I have shown you just a single tuberculoma, but patients can have multiple tuberculomas. And remember, again, this is a contrast-enhanced T1 MRI. Then there are infarctions that occur in TB, and the infarction most commonly occurs in the region of the basal ganglia. And the imaging of choice would be the diffusion-weighted imaging, as you see in this picture. And then you have the spinal TB, where you have caseous collections, you have paraspinal collections and vertebral destruction. On left, you see the MRI, and on right, you see a CT with a psoas abscess. So then how do we make a diagnosis of TB meningitis? Definitive diagnosis, we have learned, is notoriously difficult. So we move one tier down and we make a probable diagnosis based on multiple sources of evidence. So what are these evidence? A typical clinical presentation, elevated inflammatory markers, a MANTU test that is positive. Remember, again, a negative test does not rule out. It is good to rule in, but it is not sensitive enough to rule out. If a chest X-ray shows you either past or present TB, that helps with your diagnosis. If the CSF profile is typical, and if imaging, as we saw, shows the typical changes of TB, then we can make a probable diagnosis of TB. Now let us move on to the challenges with treatment in TB. Now the biggest challenge that we have with TB is that we do not have evidence for CNS TB. We extrapolate the evidence from pulmonary TB to CNS TB, and so we use the first line for medications for the intensive phase, the rifampicin, INH, pyrazinamide and ethambutol for the first 2 months. And then we have a continuation phase of 10 months. So that is where it differs from pulmonary TB, because pulmonary TB, we give only 4 months of continuation phase, a total of 6 months. Whereas in CNS TB, we treat for at least 12 months. But the crucial thing is the last column there, the CSF penetrance. And you will notice that rifampicin, which is the most important drug, has a poor CSF penetrance. Then if you note in comparison, the second line drugs like levofloxacin, moxifloxacin and linezolid have good penetrance. So there have been trials where they use intensified anti-TB regimens using high doses of rifampicin and adding second line medication. But unfortunately, this study showed to show any survival benefit. There was another study where they added linezolid to the standard regimen, again did not show any benefit. So that is the bad news. But the good news is there are a lot of ongoing trials looking at different regimens for CNS TB. So we'll have to wait and hopefully that we will get some evidence on how to treat CNS TB better. Just a word on streptomycin. Streptomycin has to be given intramuscularly, daily for 2 months if we use that. And you will notice that the CSF penetrance is only 10 to 20%. There has not been any evidence, definitive evidence, showing a significant advantage of streptomycin over ethambutol. And secondly, the World Health Organization recommends streptomycin only if you cannot use the first line anti-TB therapy for some reason or if there's resistance to treatment. Now let us get on very briefly to the second case, which is a very interesting case. This is a young woman, 24 years of age. She presented first to us in February 2018 with fever, headache, a typical CSF, and we were lucky because we made a definitive diagnosis with a PCR positive. Her MRI scan, as you can see there, is normal. We started our anti-TB therapy and oral prednisolone. But within 2 months, whilst on anti-TB therapy, she presents again in April 2018 with right lower motor neuron facial nerve palsy. We do an MRI and we are shocked to find a cluster of tuberculomas with perilesional edema. We treat her with intravenous steroids, she improves, and we continue the anti-TB therapy, and she continues on this treatment. She gets well, she gets better, and she is discharged from hospital. We don't see her until 2021. In between, she religiously completes her anti-TB therapy, but she presents with status epilepticus. Because of the past history, we do the full workup. We do the imaging, we take the CSF, do not find any reactivation, so we treat her with anti-seizure medication, and she gets well and she goes home. Then in October 2021, we find she comes again with right hemiparesthesia. Again, because we do the whole workup, we find a reactive CSF, we find an elevated ESR-CRP, we do the MRI, and we find that there's an increase in the cluster of the tuberculomas. And you will also notice there are tuberculomas appearing also on the right hemisphere. Because of this, we recommence her on anti-TB therapy again you see, for long durations. Then again, we see her in May 2022 with bilateral visual impairment. We do an MRI and we see this cluster of tuberculomas going right across her optic chiasma. And we make a diagnosis of tuberculous optochiasmatic arachnoiditis. We treat her with intravenous steroids with not much effect, not much improvement. So we treat her with infliximab, intravenous infliximab, 3 doses, and her vision improves but does not get back to normal. And in September 2022, we start on thalidomide. We again see her in February 2024, early this year, where she comes with worsening visual impairment whilst on thalidomide. And then we treat her again with intravenous steroid, not much improvement. And then we consider giving her monthly infliximab. And we give her the first dose of monthly infliximab early in May 2024. Unfortunately, in late May 2024, she admits to the local hospital with severe pneumonia and dies of sepsis. So here is an incredible struggle with a young woman, starting from 2018, going up to 2024, over 6 years. And finally, we lose the battle. So that brings us very briefly to the paradoxical reaction. Paradoxical worsening after commencing anti-TB therapy occur in up to about 65% of patients, but more than half of them would be asymptomatic. Tuberculosis develop in up to 74% of patients during anti-TB therapy. The onset of paradoxical reaction can be as early as 2 weeks, or it can be delayed as late as 18 months. But the most important take-home message I want to tell you is that the paradoxical reaction and the complication is due to the host immunity. It is not due to the organism. The organism triggers it, but it is perpetuated by the abnormal excessive host immunity. So the host immune response will ultimately determine the nature of the disease. A little bit about tuberculous optochiasmatic arachnoiditis. It is defined as inflammation of the arachnoid mater of the optic nerve and chiasmatic system leading to visual loss. As you can see, the tuberculomas in the region of the optic chiasma. It's often a paradoxical reaction. And as I said, it is the host immune system, and studies have found an increase of TNF-alpha, which is thought to mediate the optochiasmatic arachnoiditis and most of the paradoxical reactions. So there have been case series looking at TNF inhibitors like infliximab and thalidomide, and that is why we use those. And that, however, in our patient did not show any much benefit. I come to the last bit of my lecture, just one slide on adjunctive therapy in TB meningitis. We already know the place of adjunctive corticosteroids. It's definitely beneficial because it reduces death or mortality. But most of you may not know is that aspirin has been shown to be beneficial as adjunctive therapy because it reduces mortality and it reduces the risk of infarcts in TB meningitis. It does not do so purely by its antiplatelet action, but it reduces the pro-resolving mediators in the CSF. So aspirin is a worthy adjunctive therapy. In summary, ladies and gentlemen, a high index of clinical suspicion is vital for diagnosis. The diagnosis, because we cannot make a definitive diagnosis always, when we make a second tier probable diagnosis, then it is based on a collective analysis of clinical, laboratory and neuroimaging data. And the most important take-home message I want to leave with you today is that the outcome depends at the stage at which treatment is initiated, and therefore anti-TB therapy should not be delayed for any reason. It should be initiated immediately on strong clinical suspicion. And finally, adjunctive corticosteroids and aspirin improve outcome. Thank you very much.
Thank you very much, Thashi, for that most interesting presentation on the challenges in management of TB. Our next presentation would be on Parkinson's disease, key practice aspects. That would be delivered by Dr. Conor Maguire, Vice President, International Royal College of Physicians of Edinburgh. He's a specialist in geriatric neurology. Dr. Conor is the Vice President of the Royal College of Physicians of Edinburgh and was Director of Education in the same institute from 2015 to 2019. And he's a consultant physician in geriatric medicine in Edinburgh, specializing in Parkinson's disease. He's honorary clinical senior lecturer in geriatric medicine at University of Edinburgh. He developed a pioneering multidisciplinary network of care for people with Parkinson's in Edinburgh area and is an experienced MRCP PACES examiner, having examined and hosted the examination nationally and internationally for over 20 years. Over to you, Dr. Conor.
Thank you very much, and thank you to Tissa and Thashi for great talks prior to mine. So yes, I am a geriatrician, I'm not a neurologist. In the United Kingdom, the vast majority of people with Parkinson's are managed by geriatricians with specialist training in movement disorders such as myself, because we as geriatricians are the largest physicianly specialty in the UK, and I'll explain some of the reasoning for that. In Edinburgh, when I arrived there 24 years ago, myself and one of the neurologists who had specialist in movement disorders set up a synergistic service. So we work together along with other now specialists in the area to look after people with Parkinson's in the Edinburgh area, which has worked very successfully and was a template for management of people with Parkinson's around the UK. So why is Parkinson's important? Why am I here talking to you about it? Well, it's the second most common neurodegenerative condition in the world, and it's a leading source of disability, and it's the fastest growing neurodegenerative condition in prevalence, disability, and deaths. And since 2000, the global burden of Parkinson's has more than doubled. And I have down there just some figures of the number of people with Parkinson's around the world that are estimated. 4 years ago was 9.4 million. In 2030, they will expect to be about over 12 million. And the reasons for this are, well, it's probably increasing numbers of healthier, older people. So when I started as a geriatrician 30 years ago, the vast majority of people on my wards were in their 70s, they had chronic obstructive airways disease, they had heart disease. Now they're in their 90s and over 100. And the vast majority have chronic neurodegenerative conditions, dementia, Parkinson's disease. This just gives the idea of the number of people with Parkinson's in different countries and the prevalence and the burden figures. So there's higher prevalence in countries like the United States, Western Europe, lower in places like Africa and Asia, particularly South Asia, where the prevalence here is about half that of what we see, less than half in Western Europe. And there's a higher prevalence among women in Southeast Asia. And we're not sure exactly the reason for that, but we do know that the rate of people of Parkinson's is rapidly increasing in South Asia. Why a geriatrician? Well, it's a disease of older age. The average age of onset is now in the early 60s, at 65. And in the United Kingdom, our prevalence figures show in the age 30 to 39, it's 0.4 per 100,000. But if you're over 65 and if you're over 80, it's 170 per 10,000. So 4% of our population in the UK aged over 85 have Parkinson's. And the years living with disability rise rapidly if you have Parkinson's. Now, this is quite a detailed picture, and I don't expect you to be able to read everything. It actually looks slightly blurred, but it's showing the time course of Parkinson's, and I think my slides will be made available. So we don't know the cause of Parkinson's. In some younger people with Parkinson's, there's a genetic component, but the vast majority of older people, it's sporadic. And it's felt that the neurodegenerative changes in the dopamine part of the brain start maybe 20 or 30 years before clinical motor symptoms arise. So many years before, some people with Parkinson's say they're more prone to constipation, they have more anxiety symptoms, they may have some REM behavior disturbance, more vivid dreams. They may lose their sense of smell in the few years before they present with, for example, a tremor or bradykinesia or falls and come along to see somebody like myself or a neurologist and are diagnosed with having Parkinson's. So this is called the pre-diagnostic, you'll see at the top, stage of the condition. And then the person will often be seen, will be assessed, maybe started on treatment. And often what happens then, I'll just show you, these are the sort of changes you get in the brain where the substantia nigra, dopamine neurons stain dark, and they fade as the neurons fade. And as the condition progresses, we go towards through the diagnostic and then maintenance phase. We get somebody started on medication, they're stable on medication for a number of years, Then a complex stage arises. And in the complex stage, the medication isn't working as well. The person can get wearing off of the medication. They may get dyskinetic movements like this as a result of the medication. And they may get non-motor symptoms, which I'll go into in slightly more detail in a second. And this is when the drugs become less effective. And then there's a phase, the last phase is called the palliative phase, when the drugs don't work as well, and often in the palliative phase we reduce or stop medication because the side effects of medication, which may be neuropsychiatric, which may be hallucinations, psychotic symptoms, which may be disabling dyskinesias, are worse than the stiffness that occurs as a result of the condition. And the palliative stage of Parkinson's is estimated to last around 2 years. So it's not like a rapid cancer palliative stage condition. It can be 2 to 2.2 years is how it's estimated. And you see down the bottom, drug treatment. When drug treatment is effective is kind of from the diagnostic phase through to the late complex early palliative stage. So we don't use drugs for Parkinson's throughout the whole time of the condition. So just some quick key practice aspects. When I put that up, it'll be familiar to anyone who has trained as a doctor. The quadrant, it used to be a triad, but it's the 4 things that people with Parkinson's have to be diagnosed with Parkinsonism. So they need bradykinesia, slowness in movement, slowness in repetitive movement. So when I see people, I get them to tap their fingers, tap their feet, and I look to see is there a gradual slowing on one side with decreased amplitude of movement. There's also reduced facial expression called hypomimia, reduced rate of blinking, reduced fidgeting. So one of my medical students said, it's quite interesting, he said, I've looked at your waiting room, and there's half of the people in the waiting room in the clinic are like that because the tremor is made worse by stress, and the other half are like that. And I said, yeah, that's exactly it. It's from the bradykinetic type of people with Parkinson's to the tremor-predominant people with Parkinson's. So you need bradykinesia for a diagnosis of Parkinsonism, plus either postural instability, and a lot of this is due to axial rigidity because the muscles are stiff, people don't swing their arms as much. And I used to get medical students to run down the corridor with one hand by their side, or basically our 2 hands by their side. And I say, how stable do you feel when you're running with one hand stuck by your side? You don't feel as stable. You're more likely to fall when you're turning. A tremor, classically the pill rolling tremor, and rigidity, cogwheeling, which is increased tone with a tremor on top of it. We all know that. That's what I learned when I started doing neurology. But what I see most now in the clinic are the non-motor symptoms. It is a whole system disorder. So people are diagnosed, they've mainly motor symptoms, but non-motor symptoms are really common. Most people with Parkinson's will have problems with their bowels. They will have constipation. A lot of people will have overactive bladder. A lot of people will have excess salivation. It's not so much that they're producing more salivation, it's that the rate of automatic swallowing is reduced. So saliva builds up and tends to drool. You can get blood pressure, autonomic changes, so you get postural hypotension. You can get excess daytime sleepiness and REM behavior disturbance. So the person, instead of being almost frozen when they're having REM behavior, they thrash around and they live out their dreams. And I had one patient a few years ago whose husband was he was a retired boxer, the patient, and his wife came in with a big bruise on the side of his face because he dreamt he was back boxing in the ring again. But the mental state symptoms, so my thesis, my work was in dementia and in Parkinson's dementia and Lewy body dementia. And the mental state symptoms are very common. Over 60% of people with Parkinson's will develop neuropsychiatric symptoms at some stage in their disease condition, including dementia, including agitation, including depression. It's sometimes difficult if somebody is very hypomimic and they're like that to work out if they're depressed. Often they look depressed, they look psychomotor retarded, but when you talk to them, they say, no, everything's very nice and I'm happy. So it's important to follow people up over time. And the thing, take-home point to all of you, if you're seeing anyone with Parkinson's in hospital, number 1, don't be afraid to talk to the person, to get more history, and to ask about, like, let's say, motor and non-motor symptoms. And don't be afraid to consider intervening if there isn't a friendly neurologist or geriatrician with special interest around. So constipation, look at their diet, maybe consider an osmotic laxative. If they're having sleep problems, maybe the medication, if it could be that they're very rigid in bed overnight, they might need a slow release levodopa. They may need, if they have anxiety or depression as well, something like mirtazapine, an antidepressant with sedative effect might help. There are other medications that we sometimes use that's better with specialist opinions, like modafinil, melatonin, and trazodone. If they have REM behavior disturbance and it's causing them a lot of distress, sometimes an agent like clonazepam at night is very helpful. If they have excess salivation, one of the best treatments is sugar-free chewing gum, because that makes you swallow automatically faster. We occasionally use atropine drops, eye drops, into the mouth to reduce the amount of salivation. Occasionally hyoscine, either patches or tablets, patches behind the ear, and sometimes Botox injections. One of my colleagues does Botox injections of the salivary glands. If somebody has overactive bladder, again, it's simple treatment like double voiding or remembering to go to the toilet more frequently. A bladder scan, PVBS is post-void bladder scan. We use an agent like mirabegron sometimes if somebody doesn't have a retention to try and help with the bladder overactivity, and occasionally Botox. And then briefly, I'll just talk about the neuropsychiatric features. It's very important if you are looking after somebody with Parkinson's in hospital to do some sort of a cognitive assessment, whether it be an MMSE or a MOCA, to just see what they're like, and so that we can compare that before and after. We occasionally use cholinesterase inhibitors, particularly if somebody's developing cognitive problems and has hallucinations. If somebody has depression or anxiety, we do things like the hospital anxiety and depression score. And briefly, if somebody starts developing psychotic symptoms, I talk about the slippery slope of psychotic symptoms in Parkinson's disease, where it starts with daytime sleepiness, maybe some illusions, vivid dreams, and can develop into hallucinations, delusions, and then an organic confusional psychosis. And one of the main things I do at that stage, at the early stage, is start pulling away their Parkinson's medications, because the Parkinson's medications can make these worse. So most people who have any neuropsychiatric manifestations end up just on levodopa, on L-dopa, because a lot of the other medications are not very kind to the brain. And I may consider an agent such as rivastigmine or an antipsychotic medication as well. This looks like this is one of my favorite diagrams. I did this many years ago to show the presynaptic neuron and the postsynaptic neuron. And normally dopamine or tyrosine is converted to L-dopa, converted into dopamine in the presynaptic neuron. It hangs around in vesicles. It's released into the synapse and stimulates the dopaminergic receptors in the postsynaptic neuron. If it's not released, it's broken down by monoamine oxidase B from the mitochondria in the presynaptic neuron. If it is released and not taken back up into the presynaptic neuron, it's broken down by CO-methyltransferase. So this shows where the different drugs work. So drugs like cobeneldopa and cocareldopa, they're the precursor. They provide levodopa into the system. And these are the drugs that at the end of the day work best. So they're known as Madapar or Sinemet. There's other drugs that inhibit monoamine oxidase B, like rasagiline and selegiline. I rarely use them. One of my patients called them little chocolate drops, and I said, why? And she said, well, they do just what chocolate drops do, which is nothing for my health. But there's a drug called amantadine that's rarely used because it has a lot of side effects that stimulates the release of dopamine. There's dopamine agonists that stimulate the dopaminergic neurons. So there's ones called ropinirole, pramipexole, and there's a patch we use called rotigotine. I don't think is available here. But it can be useful. I'll explain why in a second. And then there are drugs that block CO-methyltransferase, entacapone, tolcapone, opicapone. They're called COMT inhibitors. And these stretch out the effect of the levodopa. So you give them with Madapar or Sinemet. Now, I know I'm going through loads of medications. I know most of those medications are not available in many countries. But I say, do not despair, because there was a big trial done a number of years ago called PD-MED, which looked at people starting on a monoamine oxidase B inhibitor, a dopamine agonist, and levodopa, so Madapar or Sinemet. And they followed them for 7 years, because when I was training, I was told, don't start somebody on levodopa, because within 5 years, they'll have a 50% chance of having disabling dyskinesias. So we were very wary about starting people on levodopa, Madapar, Sinemet at the beginning. So this trial, done over many years, found that after 7 years of treatment, anyone who was, the vast majority of people on a monoamine oxidase B inhibitor and dopamine agonist had stopped it and transferred over to levodopa because they couldn't tolerate it or it wasn't doing enough. And after 7 years, the amount of dyskinetic movements was just the same on whichever one you started 7 years before. And it wasn't 50% of people getting disabling dyskinesias after 5 years. And the reason for that is, many years ago we started people on loads of levodopa at the very beginning, and they got a great response, but it ran out, their systems couldn't tolerate it after 5 or 6 years. They became very dyskinetic. We changed, so we start low doses of levodopa and gradually reduce over the years as their own dopaminergic neurons reduce. So at the end of the day, the main drug I use is levodopa, co-benyldopa or co-caroldopa. I occasionally use some of the other drugs as an add-on medication, but in the vast majority of older people, they want to feel better as soon as they start it. They don't want to start one of the other medications which have a higher association with, for example, neuropsychiatric side effects. Just some other key practice aspects. And one of them is, it's vital with people with Parkinson's that there is a multidisciplinary team involved. And this is neurology and ourselves working together, but also psychiatry. So I have very good psychiatry and psychology colleagues who work with us as people develop neuropsychiatric side effects. The family doctor, the pharmacist is a huge help, because a lot of these people are on multiple medications. Obviously, nurses. Now, we actually have some specialist nurses who are Parkinson's nurses who work with our patients, go out and visit people and see people in the hospital. Physiotherapy, occupational therapy, and speech and language therapy. It is important that the diagnosis and the main management and follow-up is by a specialist. If you're not a specialist and you see somebody with a tremor, do not start treatment. Send them to somebody who has specialist knowledge. And the reason is 9 out of 10 tremors are not Parkinsonian tremors. A lot of older people slow down and it's not Parkinson's. So it's very important that somebody is not seen and diagnosed and started on treatment by somebody who doesn't have expertise. But it is vital that you teach your hospital teams. If you're an acute physician, if you're a general physician, if you do any general medicine, whatever specialty you are, because they will likely see people with Parkinson's, because hospitals are dangerous places for people with Parkinson's. You have doctors going around yielding drugs that are antipsychotic medications like haloperidol, which can be very detrimental for anyone with Parkinson's. You get drugs not being given on time, because it is vital that levodopa is given on time if you have Parkinson's. The drug is not available. It's just ticked, the drug isn't available, but nobody went looking for it. But if a person with Parkinson's misses their 12 o'clock levodopa, they can completely freeze. Hospital infections, more predominant, and strange environment if anyone is prone to neuropsychiatric problems. We did a study a few years ago where we looked at all the people who were coming into our hospitals in Edinburgh who had a diagnosis of Parkinsonism or Parkinson's disease. And we have about 2,500 people with Parkinson's in the greater Edinburgh area. And we saw there was a mean number of 2.6 people with Parkinsonism coming into hospital each day. So a GP, a family doctor, will have very few people with Parkinson's on their books, but if you're a doctor down at the front door of the hospital, it is likely you will see people with Parkinson's on one of your on-calls, particularly as the population ages. So it has an impact on hospitals and health services. And the vast majority of these people come in with infections, not with falls. Pneumonia and urinary tract infections were the cause of most people. And basically they get an infection, and as with a lot of people with chronic neurological conditions, their condition switches off, they freeze up. It's the same with MS, same with dementia, where a person becomes more confused. Another key message is nil PO. So it's a big problem in hospital that you think somebody's going for an operation the next day, somebody can't swallow. You cannot let the person with Parkinson's be without medication. This may mean putting down a nasogastric tube and giving them, crushing the medication, giving them dispersible version of the medication, or crushed Cinemet or co-caraldopa. They must receive their standard Parkinson's medication. Now, in certain places like the UK, we can use the patch, which can be used instead of the crushed medication. But otherwise, try and get a nasogastric tube. Just remember that an operation, nil PO, doesn't always mean no medications orally. A friendly anaesthetist will probably tell you, yeah, no, it's fine. They're going for an operation in the morning. Just give them their dispersible Madaparna, a little bit of water, dispersible co-beneldopa. They can have it an hour before the operation. So always ask up. And maybe if there's a speech and language therapist, ask them. There is a thing called the parkinsonscalculator.com that if you want to see how to convert a person's normal Parkinson's medication to the dispersible forms, this can be very useful. It's called the optimal calculator that we helped develop. So it's called parkinsonscalculator.com. So just nearly finished, some key practice summary. Hospitalization is common in people with Parkinson's. They have a longer length of stay in hospitals than people who don't have Parkinson's. Medication errors are common. Neuropsychiatric errors features are common. Mortality is significant. About 17% of our people who were admitted with Parkinson's died. Consider nil PO. Talk to your trainees, talk to your junior doctors and say, you know, if you see somebody with Parkinson's, don't just not give them their medication if they're nil PO. Think, how can we get their medications in fast? Do the basics well with the person with Parkinson's. So if somebody comes in with the delirium, try and treat it fast and monitor how their Parkinson's is and try and get the multidisciplinary team involved early. The other thing I was going to say is anticipate the palliative stage. I know you're all wanting your lunch. I'm finished in just a second. Anticipate the palliative stage of the disease. If somebody is approaching the end of life, talk to somebody who knows about Parkinson's and says, do they need their medications now? Talk to the family, talk to the patient, and think about the causes of deterioration, because aspiration, speech and swallow problems, and infection are very common towards the end of the life. And often I go in and talk to families and they say, look, can we just stop medication now and let the person fade away naturally? So just to conclude, this is my last slide, diagnosis and long-term management should be by a specialist, but anyone caring for adults in hospitals should have basic knowledge of Parkinson, especially those working at the front door of the hospital. Watch out for non-motor symptoms. Levodopa remains the main medication and the best medication. Make sure medication is given on time. Don't suddenly stop medication without consulting somebody who knows about Parkinson's. Nil PO does not mean nothing orally. Involve a multidisciplinary team and anticipate the palliative stage of Parkinson's. And I'll leave you with, and the care of older people with Parkinson's, the majority should include geriatricians. Just say that to our neurology colleagues. I'll leave you with Edinburgh Castle. Thank you very much.
Thank you, thank you, Conor, for that excellent talk. Can I invite you to stay on stage and also invite the other speakers as well on stage. I don't think we've got time for questions, unfortunately, because we are running late with regards to our schedule. Take this opportunity to thank all the speakers for this the excellent session on neurology on behalf of the CCP. Can I invite Tissa to accept our token of appreciation? Can I also invite Professor Chang to come on stage to accept the token of appreciation? Yes. And last but not least, Dr. Conor as well.
Thank you.
Thank you. Thank you. So, yeah, can I invite all of you all to photo opportunity?
Thank you for that insightful session.